This is just for general discussion for those who are interested in what's going on in healthcare today. We all know it's not good. There are a lot of things that are not good for both patients and for docs, and we just want to have a forum where we can talk about it, hash it out, find out what your problems are. What things do you notice? For your, as if you're a practicing physician or a specialist or primary care, what do you notice that it could be done better? Are you having trouble getting paid from insurance companies? Do you have trouble with your medical records, trying to get records completed on time? Do you have trouble with overcrowded emergency rooms, not being able to get your patients admitted to the hospital? What kind of problems are you having? Let's find out what they are and see if we have any possible solutions. And I'm recording these sessions so that we can, go look back at them and see what people have said. And I won't use any names, but I can get information from these sessions to let legislators know what we're finding out. What are people complaining about? What are possible solutions? Um, so if you can list for me three things that are really bothering you, or even one thing about your practice or about your last experience with healthcare, let us know here.
So, you and I spoke earlier today, and I'd like for you to expand on it. We talked about the whole idea of um, prior authorization. Of the total number of times that you've had to be arguing with whoever it is at the third party payer, what percentage of these prior authorizations do you believe could be thrown out or reduced or eliminated?
Every one of them, none of them are necessary. I mean, the insurance company says it costs, saves their costs. It doesn't save my costs or doesn't save patient costs. Um, but if I order, and sometimes it's not even a very expensive drug. I mean, I've had to do prior authorizations for Valium before, for a very low uh, level prescription for it, 2.5 milligrams once a day or something like that. It was, just uh, sometimes they're expensive, sometimes they're not. The insurance company just says that they want to make sure that the patient is getting a proper drug at an affordable cost. Well, I'm sure they're really not concerned about that. What they're concerned about is putting out the money for expensive medicines, and they don't want to have to do that. And they
So, what
want
would you
me
think
to
is
have to suffer because of that, or patients. And there's a big delay on getting drugs that people need. Antibiotics, for example, if somebody calls me with a UTI on a Friday night and I call in a prescription, even for something like amoxicillin, I had somebody that had to do a prior authorization for that. Well, they couldn't get their drug until Monday.
so what do you think is the average duration of physician time in trying to establish a prior authorization for something as simple as, let's say, a prescription? Do they spend 10 or 15 minutes, or how much time do you think is the average?
Well, I had it worked out in my office, so I didn't have to spend a lot of time on it, to be honest. I would get the notice, I would shake my head a few times and grumble to myself, and then I'd call my nurse and say, "Can you please take care of this?" And she was usually able to do it.
Okay, so the physician can give up this
Delegate
task
it.
to a colleague, not a colleague as much as somebody else on the staff in their office.
That's right.
But let's say something's more important, like you want to schedule a chest x-ray because an individual has a chronic cough. what would be the average if it's denied? What is the sort of the average length of time that you or the staff have to be involved in getting that approved?
It really is a pain. First, we have to get the right phone number to call, which is sometimes not correct. And anyway, got to get the right phone number. You have to get their Medicare number or insurance number, whatever that is, the member number. I have to have all that in front of me before I make the call, and then I can call. And then usually the number that I call isn't the right one. They have to reroute it to somewhere else, and then but eventually I get through. That that takes at least 10, 15 minutes. And then when you finally get through, it's usually with somebody that is like a clerk or somebody that doesn't know anything. So you have to explain the whole thing to them. And then they say, okay, wait a minute, I'll get a provider to talk to you. So they put me through to an ophthalmologist or somebody that knows nothing about what I do. And then you explain the case to them. And then they either say, okay, well, I'll approve it. Here's your approval number. And, you can go from there. So then you hang up and then you give the approval number to your office staff up front. Then they have to call the hospital or whoever's going to do the x-ray. And then they give them the approval number and then they'll go ahead and do it. So it's at least 15, 20 minutes messing around with
Oh,
that.
this is a non-reimbursable expense as far
Yeah,
as you're concerned in the office.
yeah,
Yeah.
definitely.
No. And would you say, do you ever get left on a phone call where you're waiting for the operator to answer, and so you're listening to the canned music?
Yeah,
That happen a lot.
yeah, not a lot, I wouldn't say. Not for those calls, but pharmacy calls or something else. But I get left on there for a long time. But but no, the calls to the insurance company, not a lot of that.
Yeah. But the pharmacist itself, if you're calling them, if you didn't have a staff member doing that for you, you might be sitting there for 5 or 10 minutes waiting for them to be able to pick up.
That's right. I do a lot of that. I did that myself.
So, is there a possibility that for the pharmacist, you can send an email to the pharmacist? Is that doable? No.
No,
You still have to talk to
do
them.
but we do in our software, in our Athena program, we do have the ability of sending them a prescription electronically. So we did have that ability. But frequently there were times it didn't go through, or I just had to specify something in particular with the pharmacist about the particular prescription. There were many times when I just had to talk to a pharmacist, and sometimes it was after hours when I couldn't do it on the computer. There's a way of doing it on the computer even after hours, but it's much more cumbersome.
Hmm.
So I would, and often I'm not at home, so I'm sitting in a restaurant calling a prescription in, things like that.
That's a very inconvenient use of your time.
Yeah.
So let me ask you, I realize you're an internist and not a surgeon, but
Right.
say a surgeon wants to perform a simple case like, let's say, a simple hysterectomy on a woman for uterine fibroids.
Mhm.
What percentage of those cases get initially adjudicated as a problem? Do you have a feel for how many are rejected initially?
Boy, I couldn't, let's see, how many, I usually end up finding out about it, although the surgeon is the first to know. Um,
I mean, is it
Doesn't happen very often,
so
not surgery.
if there are 100 hysterectomies, what is the percentage for initial denial? You don't have that good number.
No, it's not a high number. It's got to be like 1 or 2% at the most.
So
They don't get
for the
rejected.
surgeon who's complaining that they seem to have a high denial, is that related to the procedure?
Um, it could be urologic procedures. They might get denied.
I see.
Hysterectomies, I haven't had too many denials there. Hernia procedures, no, they usually don't get,
Yeah.
we usually don't get denials for those things too much.
So it would seem to me that if there's a huge number of problems, let's say there are 100,
Yeah.
what just by simply reducing this number by, let's say, 30%, how much time and effort do you think it would save in the medical practice? Just
I
what you
think
think
it
is
would,
an estimate.
I think it would save me a lot of time, probably, and I'd probably earn, I mean, if I could fit a patient in every time I had to do something like that, I'd probably earn an extra 30%, I'd say, because it takes 30% of your time to do it. Um, and it happens a lot more in general practice than it does in surgery, I'm sure, because if we do a physical and we don't put a diagnosis code in, they won't cover it. So
Hmm.
then they'll send it back to you, and they'll say they need a diagnosis. So you end up, you know, figuring something out. You sort of have to fib, like you have to say, well, this person has a cough. Well, everybody coughs once in a while, so you put that down. It's not really right, but I mean, the patient shouldn't have to pay $200 for an annual physical that their insurance should be covering. Uh,
I,
Now,
yeah,
sometimes
I
we'll,
think the issue is if we were to go in and let's not take the Doge example, which has happened recently, but if we were to go in and say, let's try and reduce the burden of pre-authorization, what would be the priorities? Would you have some idea of what priorities you would give in terms of what diagnoses or what conditions would be the easiest to eliminate right off the top? Simple cough, simple prescriptions.
I think proton pump inhibitors would be good, because, if I have somebody that's been on all of them already and they're really not getting better, if I want to prescribe one of the newer ones that is definitely known, like Dexalant, that really is considerably better, but it's also more expensive. Well, the only reason I would write for that would be if they've already tried all the other ones, and this is the one I think that they might do better on. Um, I've done that a bunch of times, and so they always send it back saying, "Don't you know that there are other, proton pump inhibitors that are less expensive?" And then you're required to go look through all your records and see all the ones that you've already prescribed for that patient, and then you have to say how long they were on it and what was the result of the of and why didn't it work, or how long they were on it, and did it work or not, and did they have a side effect. And so they're like they probably have been on four or five of them before I would choose Dexalant. Well, that's going to take an hour. uh,
That's amazing. How is it? What is your experience with this problem where we had to have pre-authorization for so many things?
oh, it started out being, I don't know, it was an annoyance, but it just got to be more than that eventually. Uh, it just takes a lot of time, and it just is frustrating, and they're denying things all the time, medicines, even life-saving things. They don't
So
deny speed.
how can we get rid of this pre-authorization? Does this require an act of Congress or
Yeah, it
you
does.
think an act of Congress?
It's a national thing. It's all over the country. It would require um, Kiggins to create a bill to eliminate all prior authorizations. And then if that would go through, then that'd be wonderful. But that's probably not going to happen because insurance has a huge lobby up there, and anywhere where legislators are influenced by insurance company lobbies, it's not going to go through.
Yeah. So it seems to me that doctors are often inadequately prepared. So if you were to go back to your local representative in Congress and say, this is the problem, that if you look at the overall cost to the community for pre-authorization, what is that? How do we measure that cost? Where would we find that piece of information, and how much could be saved
Well,
by getting rid of some of this?
you really would have to clock how long it takes you to take care of all of them, take
Mhm.
care of all the different, prior authorizations that you have to do. Some usually they're successful, sometimes they're not, and then you have to choose a different drug. Um, if you go by the denials of certain procedures, that takes a lot longer. You'd have to clock it, and see how much time you actually spend on it. And then, write it out every day over a period of time, and then multiply that by how many other doctors go through the same thing. Um, and you'd come up with a number. I'm sure it'd be a significant number. Uh,
So when you say there's a lot of procedures, certain procedures are denied very highly. Is there again a database that is accessible of the number of denials for, let's say, a gallbladder and acute cholecystitis type of thing?
I don't think so. Not that I know of.
So you don't
You have
think that
to
the third
keep
party
track of it
payer
yourself.
capture that information? They wouldn't know themselves how much they are rejecting.
The surgeons would. Um, I don't. I don't think procedures are denied that often,
Uh-huh.
unless
So
it is like for a hysterectomy that the insurance company doesn't think is necessary. But
So let's take your opening remarks where you said something like just a simple prescription might take 15 minutes.
yeah,
If we take, let's say, 1,000 physicians in the Tidewater area of Virginia, that every day they spend 15 minutes on that, we're now talking 15,000 minutes.
yeah,
That's
and
something
we're
like
talking
200
about,
hours.
and it's several times a day. It's not just once a day,
Aha.
multiple times a day.
So if you consider that when you interrupt your patient flow to handle a problem like a denial, that also adds to the inconvenience for the physician.
Plus, it's that fewer number of patients that can get in that day. I mean, it uses up any extra time that I might have to see another patient.
Yeah. So overall, there's got to be some way that we can trap or we could capture the inconvenience plus the loss of time related to actual patient care in terms of an average number per day of denied procedures, drugs, or whatever.
See, we'd have to have a way of tracking it. The doctor would have to write down, just like lawyers do. They'd have to,
Yeah.
write down the time that they spent on something. So they'd have to,
Yeah.
keep a track
So,
of it.
so this is such a nebulous concept. We could do all kinds of brainstorming and estimating, but I just really feel like in order to present a reasonably cogent argument against prior authorization, we have to have some basic knowledge of how much time and effort is spent by the average doctor.
Yeah,
I don't know who would track something like that. I would think that the insurance carrier ought to know how much time their individual people spend on any one callback for authorization.
yeah, they might know.
So every
Yeah,
time the insurance company has a person talking to the doctor, if that's 10 minutes, then you can look at the number of times those calls come in per day.
Yeah. Maybe if they would release that information, they might have it. Otherwise, the doctors are going to have to be like lawyers and keep track of their time spent on that stuff.
Yeah, I understand that, but keeping track of the time that you spend yourself is very difficult.
I
I'm
know
I'm looking at more.
I wouldn't want to do it because it's just another thing you got to do.
Yes, well, it's another inconvenience and interrupter. That's all there is to it. I'm just trying to think of other than to say we feel like this is a burdensome problem. There's got to be some means of being able to say to your congressperson who we're going to talk to about relieving this problem, how much we can save in time spent, not only physician time, staff time, patient time, etc.
You know, I have a friend who spent most of his career being an HMO administrator. And I'm going to ask him next time I see him. He's retired now, so he doesn't have to, you know, be, he's probably not under any kind of disclosure agreement or anything with any company now.
Yeah.
So maybe I could ask him.
And on the other end of the line, as you pointed out earlier, sometimes the physician you get who's going to be the adjudicator for your complaint isn't a specialist in your field.
Yeah,
So that they have to go find another expert
yeah,
somewhere else. Yes.
right.
It sounds to me like it's a very inefficient mechanism. That's all
Oh,
that's basically from what you told me.
totally. I think, it's a waste of time for me, unless I can get an approval. Sometimes they'll still deny it, like I don't know, sometimes I'll order a CAT scan of the chest and, I know what's going to happen is if I have to deal with the insurance company, if they deny it, then they're going to say, well, you should get a chest x-ray first. Well, that's going to cost them that much more money because I know I need a CAT scan for this patient. I mean, if the person's coughing up blood, I need a CAT scan. I don't
Yeah.
care.
Yes. Well, that's
And
rather obvious to me.
yeah,
But, but it's but
and
it's
we
not
don't,
to the people on the other end that are trying to maintain an income stream. That's all there is to it. A
yeah,
profit motive. It's the profit motive that's the driver.
yeah,
If they can get away. So recently, you and I had a conversation with one of the local radiologists about the overuse of MRI and CAT scans in the
yeah,
emergency room. But in the
yeah.
emergency situation, do you have to get a prior authorization before you order a test?
No, no,
Oh,
you're allowed to order anything you want and it's done, but the insurance company may balk at it later, but yeah, they'll get it done right away.
yeah. Interesting. It's a who can you gouge easiest, and you gouge the practicing physician.
Yeah,
And is your experience in talking to other physicians in practice that this is across all specialties and all
I,
physicians?
I think it's mostly for the primary care people because I think we're the sort of the triage people and people come to us with their complaints first or to the ER. They come
Uh-huh.
to us with their complaints if it's not an emergency, and then we order those tests. And then, we usually don't send them to the specialist first. We usually just order the test, try to make a diagnosis, and then send them to the specialist. Now, you know, if if we're trained to do something different, then let that be. I mean, I just think if somebody comes in with a headache, they don't need a neurologist right away, or somebody comes in with chest pain, they don't need a cardiologist right away, unless I see definite signs that they do. Um, so I might Somebody comes in with chest pain, I'll order a stress test and an echo. Well, the cardiologist is going to do the same thing, and you can't get him in to see the cardiologist for 3 months anyway. So, I mean, I think I should be able to do some initial diagnostic studies and that's what we're supposed to be, are diagnosticians. So, anyway,
But
some
Dr.
of the
Warth, how many years of experience have you had in general internal medicine?
I'd say 51, 52. I mean, I started if you count my residency.
Yeah. But in those 51 years, things have changed, things have gotten better or worse. But how about the younger person out only 2 to 5 years without an experience to make a judgment decision between a cough with or without blood
Yeah,
and a general cough and the duration for some time? Do you
yeah.
think that these physicians are less likely to use a good judgment in making an attempt to treat or diagnose?
I think they're more likely order tests than I would be. I mean, because, they don't do a good job in taking a history most of the time. As you know, I mean, if you just take your history properly, you know what the diagnosis is without doing anything. Um, if somebody comes in with chest pain and I push on their ribs and they go, ow, ow, is that the kind of chest pain you had before? And is that the same thing? And yeah, well, then they don't need anything. They've got costochondritis.
Yeah.
An inexperienced person might say, well, I don't know, it could be heart, could be pulmonary embolism. We need a, CT angiogram and a stress and EKG and a stress test and everything. So I think they would be more likely. I know ER docs are definitely more likely to order tests than I would be for various things.
So what you're really saying here is that based on experience and ability to carry out an appropriate physical examination or medical history, there are a lot of potentially overdiagnosed cases going on and are over
Overutilization of resources.
overused. Yes. So maybe the insurance company has a legitimate gripe in saying, well, we've got to have somebody review all these things to sort of temper that. What's your feeling about that?
I still think it wastes time, and um, I still think we should be allowed to order what we should order or what we need. Students in medical school and in residencies need to be taught what do they need to order and what don't they need to order. I know they were, if I had to go see somebody at 9 o'clock at night as being the resident on call, and if I saw somebody with abdominal pain and I ordered too many tests to evaluate it, the next morning I got raked over the coals because I, ordered too many tests for somebody who had gas.
Well, that certainly to me would be an appropriate response in the morning from whoever is rounding with you.
That's right.
You know,
It goes back to your training, I think.
yeah. So I appreciate having this opportunity to discuss this with you, Dr. Warth. So I hope that the people who come on board in the future and look at this get get a feel for what you really are talking about in terms of the need for experience, physical examination, and medical history in terms of the diagnostic abilities.
Oh yeah, they need to. I mean, so much of that is going away. The
Yeah.
history, and I mean, I see people after somebody's decided on what the diagnosis is, and they were totally wrong because they didn't even get the history right.
Yeah.
Um,
They're not listening to the patient.
no, they're not.
Yeah. Yeah.
They just take the main thing,
Yeah.
chest pain, but I mean, 80% of the people with chest pain have GERD, and with a careful history, you can figure that out.
Yeah. Well, I think it's been a very interesting discussion, and I thank you very much for your time and effort tonight to talk about this.
Oh, sure, no problem.
And be sure you post this one on your website.
Yeah,
I think you have great insight into the problem. I think the problem is multifactorial and difficult to address, but I certainly concur with you that perhaps the best thing we can do is get rid of some of these procedures, the necessary to get pre-authorization for a lot of procedures,
right,
and rely more on the physician ability to make an accurate diagnosis. That's
right.
what you're really saying. Yeah.
There is one other item to mention on this topic, and that is that, a lot of physicians are worried that if they miss something, they may potentially get sued later. Well, that's always a possibility, but
Yeah.
if you rely on good follow-up, then that's not going to happen. I mean, you say, well, they come in with a headache, and you say, well, you think it's a tension headache after a careful history and exam, and then, but you say, well, let's uh, see what happens. Give you try some Tylenol when it comes on. See what kind. I don't know. Some patients might be upset about that, but you might just try to explain the thing to them. Use some local heat. Take maybe a muscle relaxer. Um, uh, and see what happens. And then, but come back in a week, always schedule a follow-up checkup. And then if they say, oh, my headaches are worse and they're getting bad, well, then, uh, you can go further if you need to. But, you
Oh,
start,
I certainly understand defensive medicine from the standpoint that if you provide Tylenol and 3 weeks later the brain tumor is diagnosed, that you
yeah,
don't look very good.
yeah,
Yes.
that's right. I know. And that's the situation. You don't want to be in that
No, not
situation.
at all.
No.
Well, medicine is still evolving, and so the practice of medicine really requires a degree of astuteness on the fact that on the part of the practitioner. That's the
Yeah.
bottom line.
Yeah,
Yeah.
it is. That's right.
Well, I'm going to go, but thank you very much for your interesting dialogue or discussion tonight. I
Sure.
thought that was very, very good. Thanks. Appreciate it.
Okay. You're welcome. All right. You take
Okay,
care.
we'll see you.
All right. See you later. Take care. Bye bye.
Bye bye.